Welcome to Informed Dissent. I'm Jamie, this is Corey, and we need to talk about the AMA.
The AMA had a week.
They did. So, ASPS releases their position statement on February 3rd. The AMA, knowing the press is going to come around calling, convenes an emergency board meeting to craft a response.
Okay, that's responsible and proactive.
Very. And what comes out of that meeting is an unsigned comment. So, no names are attached, saying the AMA agrees with ASPS that surgical interventions in minors should generally be deferred to adulthood.
Great. Sounds like they're in agreement.
It does sound like agreement. And the New York Times reported it as agreement. It ricocheted around the internet as agreement.
And then the March newsletter came out.
Yeah, and the board chair wrote that was not agreement. That was a clarification of existing policy. We were not changing anything. We were preserving access
They were preserving access.
by saying surgery should be deferred.
Okay. And then what happens after that? It gets better.
It gets better. The newsletter also says that the phrasing in the statement did not come from the AMA.
The AMA statement did not come from the AMA.
Correct.
Okay. That makes a lot of sense. I guess a robot wrote it.
Well, somebody asked them that directly and they didn't answer.
So they don't know who wrote it, but they asked for a correction from the New York Times.
Well, they said that they did. The Times has not confirmed it, so no correction has appeared.
Well, they sound very organized, and this is the largest physician group in the United States.
Yeah,
And and they issued what is it? I guess they issued some sort of statement about it,
but they didn't write the statement.
uh, and it wasn't a policy change.
Well, and they requested a correction that may or may not exist.
But they said that their policy didn't change.
Yes, which is that surgery on minors should be deferred.
And they say that has not their position hasn't changed, and it's always been the same.
Yes, they said that that's what they've always believed.
Great. That's very good communication on their part.
Crystal clear.
All right, let's get on to the show.
Hi, and welcome to Informed Dissent. My name is Jamie Reed, whistleblower from a pediatric gender center, and one of your co-hosts.
Hi, I'm Lauren Legere, and I am the co-executive director of the LGB Courage Coalition and another co-host.
You were about to say collusion? Are we
Whatever.
colluding?
We're all colluding.
I am Corey Cohn. I am a former user of the application X.
You did. You quit X.
I did. Thank God.
Can you go back easily? Can you just like turn it back on?
Yeah, a little bit like the way that a heroin user can just get another hit. It's not that hard. You just find somebody, they'll hook you up.
I have an annoying cat who's like crying for reasons I don't know why. Um, no, seriously, you can just turn it back on and your profile like comes
I
back.
could. I've got 30 days, but if I go past that, then whoosh,
Oh, if you can stay clean for 30 days.
right.
Wow, it is kind of like a, huh.
It is.
You know that first hit after being clean for a while is the most dangerous.
I don't know from experience.
Well,
Well, actually, I guess I have had a couple of X accounts over the years or Twitter accounts over the years. So I do know what it's like to be in that stage where it's like, man, I've got so much time on my hands now. The only thing I can do is read books that I've had sitting around forever, or watching these movies that I was hoping to get to one day. And then then you get your social media account again and you're like riveted. Oh, what's the drama this week? Oh, there's a big expose on this crazy trans activist who keeps harassing people. I got to read every word of this. You know,
You're not missing much. Is that what you're saying?
I'm missing a little bit.
Oh,
Well, we miss you. We miss your voice.
Thank you.
yeah.
I do have a Substack, and one day I will start writing for it again.
One day you'll come back to that platform too.
The Substack, I have it. I'm not closing my Substack.
Okay, great. Well, this week I actually did want to talk about the interwebs a little bit and cancel culture and
Oh,
um
that's so 2020. Are you sure you want to talk about that?
I well, I our guest later has been dealing with this and our guest from last week is dealing with this and I just kind of want to talk about it a little bit.
All right.
Should I explain what's going on for these people?
Yeah. Who's the what's? And I'll be right back. Keep going.
Where are you leaving?
No, my cat has discovered a noisy toy, and I'm going to go put the toy away before it interrupts the podcast.
Oh, perfect. Okay, well, I'll talk and you can hear me, right? Okay. So, our guest this week is a physician, Dr. Laura. See, I'm going to have to ask her how to pronounce her last name. Schulte? Um, so we'll get into this in the second half, but one of the things she's been dealing with is that she, you know, medically speaking, has been assisting as a physician, which is her right. And part of what has happened as a result is that her online profile as being a doctor has been flooded by people who have never even been her patient, saying that she's a transphobe and that she's not a good doctor and are trying to tank her online profile and her online presence. So
Is this like Yelp reviews that are illegitimate and stuff like that?
yeah, Yelp and Google reviews are like where she's been primarily being hit. And what was interesting to me is I knew that that was going on. And then I got a phone call from Dr. Scott Glasberg yesterday, and we were talking, and he had brought forward a resolution to the New York State Medical Society. And his resolution got essentially like leaked out to, oh my God, why do we have a crying cat? What does the cat want? Can you hear him? No, then I'll ignore him. Um, so sorry. So Dr. Glassberg has this resolution for the New York State Medical Society, and the fact that he was bringing it forward got sort of leaked out to trans rights activists. And of course, they put a call out to flood the email address of the medical society, which it appears that they had done very, very well. So then, because I don't know what else to do, I put out a call to also have our voices shared. And the email address crashed because of all of this incoming email. And so we tried to pivot to a couple email addresses. But I just feel like this is this weird kind of electronic warfare over like
Yeah. So what was Dr. Glassberg, again, he was the former president of the American Society of Plastic Surgeons. What was his resolution that he was presenting? It was,
to follow the evidence for the Medical Society in New York State, and it was regarding surgeries for those under the age of 19.
so
And
his resolution is the same as the ASPS has just put out, that he would like that the medical association stop performing gender-related surgeries on anyone under 19. And
yes,
people went absolutely bananas
yes,
and flooded this email in protest.
yes. which, yeah. But Yelp reviews, Google reviews. We're going to talk about the FDA petition with Dr. Laura and Dr. Peter as our guests, but also that has been flooded. So there's an FDA petition, and now I believe the last count there were 79,000 submissions. So I just have been feeling like we are electronically vastly outnumbered.
You think there's 79,000 humans?
Um,
Well, why do you think so? I mean,
Wait, was Corey trying to imply that they're bots?
Well, I don't know if they are or not, but I think we're in the era now where it's pretty trivial to get bots to flood stuff like that.
yeah, that's something I hadn't thought of. I had just assumed, so many of these.
Jamie's like, we could use bots. That's how we fight back. We get bots.
First of all, I don't even know how to conceptualize that. But no, I don't want to do that. But um, are we electronically speaking, at least, are we still really the underdogs here?
Well, yeah, I mean, I think that the certain demographic of especially trans-identified males are chronically online. I mean, these are people that are much more web savvy, tech savvy than a lot of the
Middle-aged lesbians like
middle-aged
ours
lesbians who are
don't even
trying to
know.
fight back. Yeah, exactly. Thank you. I didn't want to say it like that, but yes, fine.
The very day she starts wearing glasses, she starts calling herself middle-aged.
Yeah,
Uh, okay, so Corey, you're male. Do you know how to use the computers better than we do?
I don't understand the premise of your question, but let me use that to just talk about something else though. Um, the reality is, and this is pretty easy to understand, there are so many people who were felt disaffected, marginalized, that felt like losers, that eventually located community in among trans. It's on Reddit, on Aaron in the Morn Substack, in the grisly places like the Discords where abuse is common, but so is community. Uh, there's a lot of those people, and they're very invested in this. And the people who are opposing it are not as invested in it because it's not as personal. If you believe, rightly or wrongly, it doesn't matter, if you believe that your continued existence depends on the availability of a certain medical regime, you will fight for everything, with everything that you've got to retain that. And the people who are not thinking that way, that don't have that type of belief system, they're just not as invested in it.
I don't know. So the people that
I also think it's an intimidation tactic too. I mean,
no,
it's
Corey, why are
definitely.
you laughing?
Because there's no engagement with the thing that I just said.
No, I was trying to engage with what you just said, but I was gonna say that I do think there are plenty of people on our quote side who are as engaged.
Yeah. Yeah,
I
I
think
would
it's a
definitely say the
I
parents.
think it's a numbers game. I don't think it's an engagement issue, but maybe that's where I'm wrong. I think it's just a numbers problem. There's more of them.
Well, I think to his point, yes, the people who are engaged on both sides of this, I think are equally passionate and are equally do equally believe that this is an existential matter. However, the people who are engaged on quote unquote our side um are fewer than the people, because you don't even have to be medicalized to call yourself trans. Right? Like this is a social contagion among very young people, young adults, and they really believe that, like Corey said, their existence is being threatened. Whereas on the other side, there are plenty of people who see what's wrong here, but also, if it hasn't touched your life personally, are not going to be sending emails like a crazy person to the FDA.
Not that it makes you crazy to send emails to the FDA.
No. I mean, 79,000 is a little crazy. But you know what I mean? Like there's people on our who are necessarily are intellectually compatible with our way of thinking, but it hasn't affected them directly, so they're not as passionate about it. Like all of us here have been impacted directly, and so we are very passionate about it. But on the other side, it doesn't take the level of connection to feel that this is an existential threat. Like this is just in the soup that young people are living in, that trans people are quote unquote being genocided every other day. So
yeah,
it's a very complex social phenomenon that's happening.
Two things have come to mind between what Corey said and what you said, Lauren. The first one is I'm thinking about the non-binary woman who sat next to me in Ohio, which I guess I could tell that story briefly because that woman was not on any medical pathway.
Oh no, she was. She had
You
the
think
beard.
so?
She had the
Oh,
beard. She was definitely on T.
she could have been Mexican American.
will you?
No, she had that weird like straggly goatee
You're
going.
right. I was more thinking about her fist in my face than the hair on her face. Um, but the other thing, and see, this is just, I guess maybe, do we know our enemy? And I'm putting this in quotes. Do we know our enemy well enough to know? Um, like, there's this kind of misnomer or like thing that's tossed around that we're up against young people who potentially don't have full-time jobs, who have a lot of time on their hands, and who do know the internet and these things better than we do, and do have more time on their hands. Are they underemployed young men in their parents' basement with
Yeah.
consistent Wi-Fi? I mean, is that a is that reality or is that like our assumption of who we're up against? Do you think that's the reality?
Well, we know it can't be the young women because they're working in Starbucks.
Yes.
Right. They're too busy.
Okay.
I'm joking. I think
Yeah, no,
there's
there's plenty of trans-identified young women that are sitting at home on disability
right.
with
Oh,
their virtue cane walking around.
Yeah. Who do you think made Tumblr Tumblr?
I don't even know what Tumblr is.
Teenage girls.
You don't know what Tumblr is. Okay, that's okay. That's all right. That's a you know what? I know that you do, but you are representing members of our audience who don't.
No, I
That's
really don't.
very
I
that's
really don't.
very
I really don't know what Tumblr is.
She has
okay.
no idea.
This is really extraordinary in a way, Jamie, because Tumblr, so it's a blog site,
Okay.
but it was ultra optimized for teenage girls. It wasn't only or exclusively for teenage girls, but it was ultra optimized for teenage girls.
How what makes something ultra optimized for teenage girls? Visual oriented, algorithmic driven video,
Yeah.
a
No
thing?
video
Okay.
at the time, but
Okay.
But
it was
also there's Tumblr in its heyday was a huge way that young adolescent girls were getting into the trans phenomena.
it was probably the first major vector of in
Yeah.
social media. And it was
Yeah.
huge.
Because again, like you just illustrated it perfectly. You have no idea what it is, and a lot of parents didn't know what it was, and their kids were on it for years. I don't think Tumblr is like the platform anymore, but it was
Yeah.
for a while a big trans propaganda platform, and parents didn't even know it was there, or what it did, or how it operated.
And it was full of adult images.
Oh,
And not for, I want to try to put this in a way that makes sense. It wasn't OnlyFans. It wasn't that type of website.
okay.
It,
I do
it
like,
was
I know what that one is.
uh,
For
good.
reasons, for different reasons than you just implied, Corey.
I'm sure that I
No,
didn't imply
no,
anything.
no, no. I know. Okay. Can I defend myself for 2 minutes here?
I think the best way to defend yourself, Jamie, is to not make admissions.
Oh my God.
Yeah, maybe you should just shh for a minute.
I
Yeah. Uh, the type of erotic stuff that was on Tumblr, a lot of it was created for the interests of young women.
Yeah,
A lot of
wasn't it
yaoi
also,
and
yeah, the yaoi and the
yeah,
manga stuff?
right.
and the
Yeah,
anime
like
and
the
the
anime stuff.
okay.
Yeah.
And it was sort of like a lot of the people who ended up moving over to Blue Sky, that type of crowd, that type of culture really had a home on Tumblr first.
Yeah. I mean, I think it's a combination of things too. It's also, I think it's an age thing too, is that people, older adults who are involved in this, yes, they might be on different social media platforms, but what they do is they check it after work, or they check it at night before they go to bed. They're not chronically on it. So with the younger generations that are chronically on it, they're gonna see Aaron in the Morn's post 10 times more, because there's all of them are just constantly scrolling. We use it as a tool. They use it as their entire social network.
Okay.
You know what I mean? I mean, there are so many different facets to why they're operating this way, but I think, particularly with the FDA submissions and the comments, the FDA very much is looking for quality of comments. So if they flooded the FDA with a bunch of "you're a transphobe" or "suck my girl dick," like that's not helpful.
If I can ask for a moment though, because we're talking about platforms and who's chronically on these platforms and that they're engaging with content. I still think that's a different thing to like absorb content and see content and like be on Tumblr or whatever. I still see that as very different than intentionally going after a physician and writing a Yelp review about somebody whose practice you've never been in. I is there are there lines? Are there like ethical
Yeah.
the way you engage online
But
lines
this is what
that
I'm talking
like
about. It's different to you. It is not different to the younger generations who were born and raised on digital platforms. It's not different. Like it's no different from them to post a nasty Yelp review than to post a nasty X response, or a comment in your Instagram feed. It's no different.
okay.
And
So
it's easy, right? You just do the thing, you write the thing and you send it, and that's it. And there's no
okay, but see, I don't see that as easy. Like writing a nasty Yelp review about somebody whose practice I see that as I'm harming this human that I like that exists as a real person.
That's
Like,
not how they see it. They see this
Yeah.
as like
Are you
they're
over 25?
oh yeah, look, I've got glasses now. I'm well
Did,
over
did,
25.
did your frontal cortex finish forming? Well, let me put it this way. Could you imagine a younger version of you that was maybe like an anarchist? where you just wanted to burn the world down and you didn't care what anyone else thought. And the last thing that would bother you is the opinion of somebody who you believed had an ideology that dehumanized you.
Okay, I'm gonna let me run with this for a moment.
Sure.
There is a different level of the amount of work that it used to take. Writing a nasty Yelp review is so different from what we back in, okay, not even use the word we. Here's an example. Back in the day before there was social media, imagine
Mhm.
that there's a group of anarchists who believe in some worldview that they want to share their propaganda or their worldview with the world, right?
Right. Meat is murder. There's a good one.
Okay, but okay.
Okay, whatever. Keep going.
So imagine these young anarchists and the amount of effort and work it would have taken to disseminate this without social media. So perhaps they might steal a universal key to all of the local newspapers boxes. Back in the day when the
Right.
newspaper boxes, you would put your money in and you'd pull it open and you could get out a newspaper, right? Imagine that
Wow. On
I
our next episode of the History Channel.
but imagine that they managed to steal a key that would universally open all of those boxes because the
Sure.
people that would feed those papers in every morning had a key, right?
This sure is a specific example, but please keep going,
Okay.
Jamie.
And then imagine that you broke into these anarchists, found a way to get into a Kinko's and run off thousands upon thousands of a flyer insert that they wanted to stick into all of those newspapers that were going out one day.
Yeah, this is
Do you
getting very,
see,
very specific.
do you see the amount of effort that would go into an action like that? That you'd have to coordinate and have friends and do all of these things, and then the physical labor that would go into
Yeah.
doing this. Um, that's the kind of effort that used to go into things like that before you could just flood a Yelp review.
Right, but what was the motivation behind all that effort? It was your social standing in whatever community you were in. It was your social relationships with these other people in your in group, right? And so that's the motivation for these kids. It's like, especially the younger ones, like this is their in group, but it is easier to just write a nasty Yelp review, but the motivation is the same.
I don't know. But I don't know. Is it? Because if the motivation is to be in your in group, I in part think that's why the single nasty Yelp review is not enough. That's how you see this like, real trolling, real threatening, angry, like social media, doesn't it push you? It's not enough to be like, I wrote a mean tweet back. You have to keep pushing it and pushing it and pushing it.
Well, these types of review sites, they're very low accountability, right? So if you go out and you say something nasty, what are the worst repercussions that you're likely to ever face?
No,
Your
I mean,
your comment will be deleted, right? That's probably about the worst thing that'll happen.
Yeah, zero.
okay, but
So
if you're in a small group of fellow anarchists in the 2 a.m. window when the newspaper's being delivered to shove in your insert that you could get arrested.
very specific example. What would the flyers hypothetically would what point would they
Oh,
be making?
I remember maybe some anti-war thing when George
Anti-war.
W. was going to go invade
Yeah,
Iraq.
yeah.
Like, do you remember that period when the whole world was against the start of
Wow.
the war?
That's a very specific hypothetical.
But, you had to have the camaraderie, you had to have the trust of, the people that you're working with, but you also had to have a clear message and a goal. And
And
yeah.
and it gave you some feeling that you understood the world and that you were acting upon the world instead of reacting to the world. It gave you a sense that there was agency and that of this injustice that existed, you could do something at minimum to raise consciousness about it.
Yes, but the other thing I think when young people operated more in that way, you were also accountable to the people alongside of you, that you were going to look out to keep them safe and make sure that, I don't know, I just see it as so different than, being in a mob online and all tweeting or all Yelp reviewing on somebody. Maybe I'm just waxing, nostalgia to the good old activist days.
You didn't used to get nostalgic, not before those glasses.
But did you, I mean, Lauren, Court, like, I wasn't the only one that was like a part of were you a part of like a social movement group that you wanted to be a part of?
Sure, there was this one group where me and my friends went testifying across the country to try to put in protections for children so that they aren't harmed by rogue doctors. I'll tell you about it offline.
Are you, uh, so
But
you're saying I haven't changed at all. I'm just,
let's talk about me.
okay.
Look. I don't want to get too philosophical here. Apart from the the fact that we can make a very strong argument that there is an injustice, that there is harm, that there are actors who have the freedom to continue harming people, and that we can see that and describe it and put a spotlight on it and even take actions to stop it, right? All of abstractly, all of that stuff that is we can talk about as an argument. Something bad is happening and we should do something about it. But we also have these bonds between us, which help us to have a sense of place and purpose. So apart from this abstract, concrete injustice, but these abstract ideas about injustice, we are doing something together because there is a communal bond between us where we give each other encouragement, where we stay in touch with each other and make sure that we're doing okay, where we learn more about each other's pasts, whether that's breaking into news boxes and stuffing them with propaganda or anything else that somebody might have done in their past. Like, we learn about each other. It gives us a real sense of belonging. And that's also what these trans people have when they're creating these campaigns to smite their enemies.
I want those young people to have that.
Yeah.
I just don't want them to damage their bodies.
Yeah, but all these leaving bad reviews, this is them smiting their enemies, as Lauren was saying earlier. This is they don't think about it in terms of, well, I could really be hurting somebody's reputation. They want to. They're smiting their enemies. Like, you would have written George W. Bush a very negative Yelp review. President, 1 star. Would not vote again.
That sounds so trite. Like, that sounds so idiotic when you say it like that.
Well, I think it really does. That's the thing, is that like even the things that they're ascribing meaning to aren't giving them the same sense of number one, satisfaction and community in the way that this hypothetical anarchist from 20 years ago was getting. Like they're not really getting that. Like they're sending off, yes, they're sending off a nasty Yelp review, and a bunch of other people are sending off a nasty Yelp review. But how many of those people you think have had sat down and had dinner together,
That's
cried together, talked about real life things other than smiting their enemies together? They haven't. So, like, even their sense of community is quite warped, and it's the only way to contribute to this community is to do things like this, then that's what they're going to do.
Lauren, I do think that is is key in some ways, is because the other part of is this radicalization? Is this like part of the process of radicalization? Because the other part of sitting down, like say this hypothetical anarchist group goes and does something like this, and you're absolutely right. Then they have to go back to, the house that somebody owns and, making vegan dumpster dived curry with rice for the group. But then you are interacting with those people on a fundamental, like in person. Is this like the real life versus just being radicalized online? And
Right, that's the thing, is like that real life anarchist group hypothetical of 20 years ago, at some point, somewhere in that relationship, it wasn't just about the cause. It was about the person, like, oh, I have to go bail my friend out. She got caught sneaking flyers into the newspaper racks. Oh, I gotta go bail somebody out. They got caught breaking into a Kinko's. Oh, I gotta go, help somebody out because their bike tire's flat on the side of the road. Oh,
Right.
it's my turn to make dinner for everyone.
there you go.
Like real, so it's not just about the mission, it becomes other parts of your life are also intertwined, and that's what real community is. So that I'm sure that these people in this hypothetical anarchist club or
Whatever.
community or whatever it was, um, could also disagree on certain things because you're getting the full human experience with each other. If you're living together, you're working together, you're doing your movement together, there's probably more of like a opportunity to disagree with each other on certain
You think
things.
it's like richer and deeper than just an
It's
online
a it's
radicalization?
an actual community. That's the thing, is that we have a generation of people who were raised online who think this is what community is, and it's not. How many of those people who sent in a Yelp review along with you are going to come and pick you up on the side of the road when your car gets a flat tire?
It's so,
Any of them? Who's
this
going
is
to
so,
help you move the couch into your truck when you're moving? Are any of them going to show up? And so these people are doing more and more to have community, and it's an empty attempt because they're not, the rest of it isn't integrated in real life dynamics.
okay.
Wow, I just sounded pretty smart there.
I'm gonna say yes and no though, because I have heard from parents who will say, my child now lives in an apartment with in a thr in a thruple with eight other non-binaries. I don't know if a thruple equals eight. Sorry, math. But it does sound like some of these young people are interacting in real life, um, on some level. So I don't want to romanticize like, oh, back before social media, it was all, roses and bailing people out. Um, but Corey, you might remember there was a news story 5 months ago. Um, a trans-identified individual committed suicide, young person committed suicide on camera online
Oh,
while the cameras were rolling, and they had been pushed into doing this.
That I have not heard.
Well, there have been several incidences like this, and not just with trans-identified, but with adolescents and young adults who are kind of in these weird chat rooms and they're kind of bullied into self-harm and suicide. Do you think that happens in real life? Like if you were in a room in a group, do you think that
That's
it
what
would
I'm
get taken to that extreme?
that's what I'm trying to get at. Would it? I
I
mean,
think I think
with the same number, and when I
right,
say the same
exactly, yeah.
number, like in like that online, I feel like in that story there were like hundreds of people watching this occur and like cheering this person on. Yes, do it. Yes, keep going. And they had this like wall because there was this wall between them because it was like real life and like online life. They were still separated. They're sitting there behind the keyboard and they're able to say, "Yeah, go on and do it." There were like hundreds of them pushing this person on. I think I would hope that if you had the same sheer numbers, that there would never be 100 people physically standing in a room with a human being that would push them, that somebody would intervene. But this is where I don't know. This is where I don't know if social and like the real life experience and the online experience is the online like just mirroring how we are, like the worst of us in real life anyway? Or like, are we just still humans in real life or online and we're just terrible humans either way?
Well, let's get together and bully Lauren and see what happens.
How many people? What do we need to bully her to do?
All of the informed dissent audience. All meet together and we'll bully Lauren and just see what happens.
Is there a research study?
She's considering it, Lauren. This isn't.
Oh yeah, she's thinking about it. That's
I'm
great.
actually trying to think, is there like a research study that has anybody tested like will a human intervene in real life faster than they would intervene in a social in an online setting? Like, do you see the research? Do you see the hypothetical question there? Like,
Yeah.
if there's 100 bystanders in real life and 100 bystanders watching something horrible happen online, is there a propensity to intervene faster if it's in real life?
Well, I think that's going to be impossible to test because online has a element to it, which is that you're never sure if what you're watching is real.
Yeah. Yeah, I think that does have it, like in the back of your mind, you can say, "Oh, this is fake." Even if you kind of know it's not, you still give yourself that deniability in your own mind, like, "Oh, this could be fake." Yeah.
It's harder to do in the real world.
Yeah.
But okay, so take this example and then turn it into the doctor's situation with the Yelp reviews. How many people in real life are going to drive to her office and fill out a comment card or complain in real life to the receptionist versus write a Yelp review?
0.
Okay.
0.
Okay.
But also, you can't do that because they're not going to take your comment card if you weren't actually a patient. They're going to be like, "Why are you here? We don't even know you."
Why did you drive from Washington State all the way to New Jersey? That doesn't make sense.
Lauren, do you want to tell Corey what I did at the coffee shop while we were in Ohio?
Did she leave a comment card?
Oh, no, but we walked into Einstein Bagels. Well, she wasn't happy with that. She wanted better coffee.
No, that is
So,
not what happened. There was a really long line. We were trying to go testify. I need espresso every morning. So rewind
She's a
story.
queen.
okay, so whilst we're in line at Einstein Bagels, she's like, and the guy in front of us was like, "Actually, the place around the corner has much better coffee." And she was like, "And we're off." So we go to this place, we walk in, and there is a um Statue of Liberty size trans flag
A whole
hanging,
wall.
whole wall in this cafe. And she gets up and she's like, I can tell she's like, what do? I need espresso, but I can't. And then she goes, she is about to order, she pulls out her card and she's like, yeah, no, I can't do it. I'm a lesbian and that flag is offensive and I can't give you my money. And we left. And I was very proud of her. The
Even though
people,
I had to go back and get in line
and then we went back and got in line at
Yeah.
Einstein Bagel.
Yeah. But at least you gave your money to a
a
big corporation
conglomerate.
instead of a
Yeah.
local.
Yeah.
Yeah.
But the three baristas just stared at me like I was insane when I was like,
Yeah, they did. They were just like, the one guy just couldn't, it didn't compute. The girl was like confused and then angry, and then I was just like, bye. And we left. Thank you.
It's a real life turf.
She does this, but
often.
yeah. Yeah.
But you were
Right.
saying in real life, nobody's going to drive to the doctor's office and say, I'd like to fill out a comment card. And I would just like to point out that I have become more and more willing in real life to, if I go into the shop and I see something like that, say, hey, I'm not going to give you my money. Like,
Yeah.
but
All right, should we move on to our guest segment?
I think we'd better. I'm not going to be there for it.
oh, we're going to miss you.
I know. I'll miss you too.
Will you, will you maybe consider writing me like just a really brief the internet 2015 for dummies and just explain Tumblr like a couple of these other platforms. You've mentioned Kiwi Farms before. I don't have any idea about that.
You'll have to send it via carrier pigeon, though. That's her preferred method of communication.
No,
No,
you
no.
have to
I have
get
a
it
better
in my
idea.
local newspaper box.
That's what I was gonna do. I'll wait for your newspaper to be delivered to your porch, and then I'll put a little flyer in it.
Oh my God. Yeah. Wow, we're ridiculous. Okay.
Yeah,
Thank
stay
you,
tuned,
Corey.
folks, because our two guests are not as ridiculous. Very serious subject.
We'll
All right.
see you next week, Corey.
All right, bye.
Bye. Welcome to Informed Dissent. We are back with two guests today. We have Lauren Schwartz. Did I say that correctly? Okay. And Peter Pitts. And we are going to talk a lot about probably two or three different topics. So, what we want to get into is the FDA petition, which is kind of the reason for us to talk today. But we also want to talk about that there is still fallout occurring for those who are talking about this issue or are willing to be public about this issue. And then third, I do want to get into a little bit of the medicine, the science that's driving part of the FDA petition. So that's going to be about what we know about the medicine of giving individuals who are male feminizing hormones, particularly the estrogen based or the estrogen medications. So I think these are our three primary topics today. What I'd love to start with is, Peter, if you could just do an introduction for yourself, let everyone listening know maybe who you are and how you came to be talking to us today.
Thanks, Jamie. Peter Pitts. I'm a former associate commissioner at the US FDA, and now I'm the president of a public policy institute, a think tank called Center for Medicine in the Public Interest. And my introduction to this issue isn't as a parent or a relative or somebody that really is that deeply engaged in the transgender issues, but rather, from an FDA perspective, what the FDA should and should not get involved with relative to the safe and effective use of various prescription drug products. And as that kind of drew me further into the political and social debate, it became really clear to me that it's a really good example of how people can ignore science when it doesn't suit their purposes, embrace it when it does, and I guess most frustratingly misrepresent it when they choose to. And that's my role here, I think, today, is to kind of speak to that topic.
Can you share a few things? So FDA is the Food and Drug Administration. And what was your background that led to you having a job at the FDA? So what kind of training or do you have?
Well, I'm not a physician, although people keep calling me Dr. Pitts. The only people, it's embarrassing to me, but my parents are very excited about that. I'm more of a social science geek, but I'm really a regulatory geek. And that's regulatory science as opposed to biological science. So, my seat on this panel is really, how can regulatory science be fair, but also robust and tell the truth in a situation where telling the truth can also be seen as extremely political.
Excellent. And then Lauren Schwartz, would you like to introduce yourself? You are an MD.
Mhm.
Okay. Well, we'll call you Dr. Lauren and we'll just call Lauren blah.
Sure. So I'm a board certified psychiatrist and psychotherapist in private practice. I've been in practice, going on 13 or 14 years now. And I've always been very passionate about providing best possible care for every single patient that I see. I've been an advocate for mental health at local levels, at state levels, and now at federal levels. But definitely not anyone that wanted to be in public speaking or I think big plat public platform. I very much love working one-on-one with my patients every day, and but what I saw a few years ago was something I just hadn't ever seen before. And I think in this entire movement, and there's so many different ways you can describe it now, whether you want to look at gender ideology and how it's infiltrated academia and medicine, and or the gender affirming care movement. Like, I think it just was something that took me a little bit off guard. I had just not ever seen anything like it, and it was kind of behind the scenes until it wasn't. I finished my residency in 2013, so it was right when the DSM was being updated. So I had kind of one foot still in academics and one foot in private practice, and it was just a really interesting time to see what impact that had then, and then how it has developed. But what I found very quickly was, I see patients of all ages, walks of life that struggle with all kinds of different things, and I'm again a huge advocate of meeting a patient where they are, and dealing with whatever they need to be dealing with in that moment, and treating them as an individual and a whole person, not just one particular thing to fix. And what was interesting was, anytime I came across, let's say, a medical intervention, that was something maybe I wasn't familiar with, I go and dig and look for, okay, where's all the research? Where can I start finding things out? And this was an area of medicine you couldn't get to. You couldn't get to the research back then. Let's go back, maybe 2018, 2017. I didn't know why I couldn't get to it. We know now. But I think it was just such a developing issue that even if I called a lab to find out about how to look at lab work, and what they're looking for, or why hadn't labs been done by a clinician, or why was something prescribed, and why was it at this level, and I couldn't get answers to those questions. And so then
were you seeing trans-identified patients?
not exclusively. My clinic is just a general practice. So were there transgender identified individuals? Absolutely. And so, but it wasn't political. I'm just a big opponent to, politics and medicine. It shouldn't guide clinical care. And this is really where things started to shift. And I think that overlapped. I'm also a mom. I have 3 kids, and at the time was seeing things kind of infiltrate their school. Not anything huge, not a big giant program that rolled out that was, very clear cut, but little questions they'd come home with, or asking me about, Mom, when did you know you were a girl, or talking about pronoun, things like that. So I started pushing back and kind of just asking the school, just, hey, what's going on? And at first it was like, well, we'll answer your questions. And then very quickly it was shut down with, we're leaning on the experts for this. And I thought, well, I'm a psychiatrist. I mean, mental health is kind of what I do. Can we talk more about it? And it was like, nope, we have guidance on this front. This is what we're doing. And just the more I dug, the more what I found was my professional association was very much in favor of pushing affirmation through in schools and in medicine and in psychiatry. And then, from there, you start scratching the surface and just seeing how much and how broad this extends. So that's long story long. I think that's how I got to where I am now. Like Peter, we don't have direct involvement of kids or family members. Of course, we know many individuals that at this point now that are involved or impacted. But really, I'm here because I never thought it'd be controversial to say that, medicine should be practiced with the highest standards and best care should always be provided for every patient. And of course, we're going to talk about risks and benefits of any intervention. So,
One
Okay,
thing, on a non-scientific perspective, just to pick up on something Dr. Lauren said, is, I live in New York, I'm from New York, as is my wife, and for about 10 years we lived in Indianapolis, and my kids were growing up, two little Jewish kids in Indianapolis. And having my kids sit in the class and having in public school and having the teacher say to my kids, well, what's it like being Jewish? It seems kind of an innocuous question, but is not. So just wanted to get that out there.
yeah. So this is what I want to first discuss. So the Food and Drug Administration oversees or regulates drugs that are prescribed and sold to us on a day-to-day basis. Is that a general idea of what they do?
The FDA regulates prescription drugs. It regulates over-the-counter drugs. It regulates dietary supplements, foods to a certain degree, and medical devices. And I'm sure I'm leaving some things out, but that's the general environment. It's got a broad portfolio.
Okay. So the drugs that are used in what is referred to as trans care include drugs that go all the way from puberty blockers, GnRH agonists, to what is referred to as masculinizing hormones and feminizing hormones. So the masculinizing hormone is really the use of testosterone, and it can be delivered in multiple different ways: injectables, pellets, gels, foams. There's an oral testosterone that has not been approved for use in the United States, but was approved in Europe. So that's kind of the range for puberty blockers and masculinizing hormones. What are the hormones that are used on the feminizing side, if we could start there? And Dr. Lauren or Peter, either one of you want to jump in?
Let me start with kind of FDA 101 here. If I get overly wordy or boring, just throw me onto mute.
Okay.
But the FDA, when the FDA approves a drug to be on the market legally in the U.S., it has what's called the drug label. And on that label are a variety of things. Most importantly, the thing that most people understand is, what is this drug approved for the use of? Okay. And that's called on-label use. This drug is being used based on the on-label indication approved by the FDA. But once a drug is approved by the FDA for an on-label indication, it can be used by any physician for any purpose they want, on-label or off-label. The physician has tremendous discretion as to how a drug can be used, and many drugs are used primarily off-label. So I think it's important. So this is not a unique circumstance. Now, the problem with the descriptions you've used for these various drugs is they are all off-label indications. And it
Correct.
doesn't mean that they're wrong, and it doesn't mean that they're dangerous, and it doesn't mean that they work or don't work. It simply means that they're legal, but they are not on the label as an FDA-approved indication. So the FDA's authority is whether or not this drug should be on the market. Once the drug is on the market, there's tremendous leeway for medical practitioners as to how that drug can be used.
Okay, can I pause for a moment? And Lauren, you might be able to help here. So in psychiatry, this is just an example. Tell me if I'm wrong, but you could have a drug that is for high blood pressure. Is guanfacine a drug that's used?
Mhm.
Okay, so guanfacine is a drug that was on label approved for use for people who have high blood pressure.
Okay.
But then off label, it started to be used as an ADHD medication. Is that, am I correct on
So we're
that?
talking about intuitive. We're talking about
Yeah.
sure. So
Is that
and
how
that's
it works?
and that you're absolutely so when you look at that and you look at approvals, and you'll see a lot of times drugs that do get a good effect do get FDA approved for that. So you'll see intuitive being approved by the FDA for treatment of ADHD.
But it wasn't
Look at
initially.
right,
Okay.
absolutely. So there can be a process of that approval. And Peter, this is obviously your wheelhouse more than mine. So you jump in if I get this wrong. So, but I think what's really important about off-label use is that you've got to look at things that are used to treat things similarly. You know, the more similar, like I'm trying to think of a good example off the top of my head of, treatments for, let's say I'm using, an anti-anxiety medicine, let's say buspirone, which is Buspar. It does have some antidepressant effects. It's not necessarily FDA approved for that use, but can I use it off label at kind of on the higher end of doses to actually have an antidepressant effect? Yes. But it's a similar treatment and patient population. So the more similar and the more known and well known the effects of the particular medication you're prescribing, the I think maybe easier or better it is so that you can justify that use. So that's the other thing that does fall on physicians is off-label use. To what Peter was saying, we do it all the time. It is very you don't realize this, but it's very difficult to get something FDA approved for anything. It has to go through so many different stages and trials, and we've got to demonstrate safety and efficacy as well as, okay, have we documented all the harms? Are there more harm signals we're not seeing? And are there treatments available now that are actually safer and or more efficacious to treat a certain um, you know, issue? Yes. So you've got to look at all of these different things. If it'd be very difficult if someone is prescribing, especially first line, something that's very harmful at very high doses that aren't similar to doses prescribed in other patient populations. And there are treatments that we know available that work well, FDA approved, or maybe psychotherapy helps better. To justify then using something in that way off label, but before now would be very difficult to justify.
Okay. Tell me what first line means.
It's what you use. It's the first thing that I go for, right? It's the medications that are typically FDA approved, that we know there's a tremendous amount of research. We can look at all of the different systematic reviews and demonstrations of efficacy. I can talk with patients about safety, about signals to look for harm-wise, if they're going to have a side effect and those side effects that they need to watch for. If someone does have a side effect or an adverse reaction to a medicine, let's say we're prescribing Prozac or fluoxetine for depression or for an anxiety disorder. It's FDA approved for depression. Okay, we try it and they have a side effect. It doesn't mean that they don't have depression. It just means they can't tolerate that medicine and we might switch gears. But all of those things, fluoxetine would be first line treatment for depression because of all of the research and data that we have. Is it going to be perfect for every single patient? Of course not.
So, Jamie, I think another way to think about it is first line therapy means that you have a patient and that patient has a medical issue. What is the best practice first therapeutic step you take to treat this patient?
Mhm.
That first step doesn't work or it's not as effective as you want it to be, you go to the next step, second line therapy or combination therapy. So first line therapy is what's best practice for the first thing that you do for a patient in a given circumstance. Now, the problem relative to what we're talking about is that these medical products are being used off-label, and that doesn't mean that there's not a lot of real-world evidence, as to the efficacy, safety, risks of a product. It simply means that people are jumping over first best practice types of therapies to get to a therapy they want to use based on their own professional judgment.
Okay. And I think could I add one additional thing to that, especially in a developing child. And we know brain development extends all the way through age 25, 26, 27 in some of these kiddos. When you look at intervening medically or otherwise in children as they're developing and through puberty, that is the most important, or one of the most important times, that you're not intervening with things that we know cause severe side effects, possibly permanent side effects. We don't go with most invasive ever. It's just, standard of care. And again, until I think this new world we live in, you don't lead with the most invasive, the most risky interventions without trying things that will let that child develop naturally and kind of hold space for healthy development and healthy puberty, which is just a huge important period of time in a child's life.
Obviously you've got the first do no harm protocol.
No question.
But you also have a lot of physicians who are using FDA-approved medical products. Let's just take estrogen, for example. And they're using it in very kind of new and creative ways, I guess is probably the most polite terms I can use. And when you interrogate them as to why they're doing that, the answer you get isn't, well, look at the huge number of well-designed, well-controlled clinical trials. What they say is, well, in my clinical experience. And what that means in the real world is, in the handful of patients I've seen, it's purely anecdotal. And the plural in science, the plural of anecdote, is not data.
Okay. So we have a whole field, and all of the drugs that are used in that field are being used off-label. But we shouldn't go and say that means that they are necessarily harmful just because they're off-label, or that they're not efficacious just because they're off-label. Because what I'm hearing is that there's a lot of off-label use, but that happens for reasons that doctors are kind of allowed to make those determinations. But is there ever a point, and I'm going to go back to when a drug jumps, so it's off-label and it's in wide practice, does the FDA ever then, can they bring that on label? Can they say, this is used so much now in this zone, we're going to test it and bring it into an on-label use?
So firstly, the FDA doesn't test products. The FDA reviews the tests that manufacturers do.
Thank you.
So when you look at a lot of the drugs that we're talking about.
Sorry, I want to drill into that for just a second.
Sure.
So the Food and Drug Administration does none of the testing on its own.
Correct.
So it is reliant on the manufacturer or the patent holder of the drug to do its own testing. And then it reviews the testing that is done, and then it gives it basically a stamp of approval.
Well, important little, intercession here is that when manufacturers do clinical studies that they're going to show to the FDA, those studies, the design of those studies is discussed in great depth with the FDA. So when the data comes back for FDA review, it's based on a clinical design that has been discussed and approved by the agency. So it's not like, hey, look, here's some data. What do you think? It's data that the agency understands how it was generated and agrees that the design of how the data was collected is legitimate.
And I'm just going to throw this out here. I know the answer to this question, but maybe the listeners don't. The first time you test either a new drug or a drug that has been changed or being, tweaked a little bit, the first group of patients you test that out on is not the general public by the hundreds of thousands, right?
Well, before you get into clinical trials, which are double arm blinded studies, which means some people get the drug and some people don't, then you compare the results. Before that happens, you test it on healthy volunteers. And you're not looking for clinical effect in those volunteers. You're looking for how, for example, how quickly does the drug reach maximum benefit in the bloodstream, things like that. It's the phase after that when you are testing patients with a given clinical condition to see how the drug impacts that type of condition.
Okay. And there's multiple different stages to these drug trials. And by the time it's out there in the general public, it's gone through, is it 3, 4, 5 different iterations of studies?
Well, it depends on kind of what's going on, but you raised an interesting point before, which is most of the drugs we're talking about today are off-patent drugs, which means that they are almost entirely, correct me here if I'm wrong, Lauren, generic drugs. Now, when a manufacturer brings a generic drug to market, their level of evidence is much lower than when a brand new drug comes on the market. Basically, what generic drug manufacturers need to prove is that their version of the drug, their manufactured version of the drug, has a similar effect in the bloodstream of the patient
Then the patent
than the
version.
patented drug. So when you're dealing with drugs like estrogen, for example, these are ancient drugs, almost even older than me, where you're not testing them for anything other than are they bioequivalent to the original drug, which is a long way off from, should it be used for different conditions.
Okay. I'm going to ask one more question and then we'll move into how does off-label become on-label and a few more things like that. But the drugs in gender interventions, these are cheap. In the grand scheme of how much a drug costs, these are really cheap. Am I right about that?
They're old drugs. They are off patent. And when a drug goes off patent, when an innovator drug becomes a generic drug, its price generally decreases from one day to the next, literally about 90%. And when you talk about older drugs, sometimes it's even more so. That is really a factor of how many companies make the drug relative to competition. But the price differential, just kind of broadly speaking, between a new innovator drug that has all sorts of nifty, cool things and an old timer generic drug is about 90% less.
And I think obviously that's not the set of medications or hormones we're talking about, but certainly I think it could be, if you look at puberty blockers, that would be the exception. That we're not
In terms
talking
of
about.
expense.
Yeah, yes, exactly.
Okay. So this might be a crude analogy, but when you're talking about on patent versus off patent, is this kind of like the difference between buying like it's Easter soon, like the marshmallow peeps that are like the brand name peeps that are like, like
Sure.
a peep, and then
I'm
you
not,
buy like the crappy ones that like are like the face isn't on right and the marshmallow is
I'm not a peep guy, but I think if you think about going to the drugstore to buy a vitamin D supplement, there's the branded vitamin D supplement that costs $70, and then there's the drugstore brand that costs $20. They are the same product, they do the same thing, they are both approved by the FDA to do the same thing. It's more like that, where it's the same product, simply made by two different manufacturers.
But does the FDA make sure that, like, if I buy ibuprofen that's brand name versus if I buy Tylenol versus the store brand, the FDA makes sure that both have like an active drug ingredient in there, but there might not the same capsule coating or they might not be. Is that kind of the difference?
Yes, that's a good kind of general way to think about it. If you want to go buy a generic over-the-counter drug, there's the brand and there's the generic. What's the difference, right? Price obviously is the first difference. Then there are differences like the color dye used in the capsule, or the excipient, which is the stuff in the pill that's not the drug that keeps it together, can be different. But the FDA keeps a very close eye on that sort of thing.
Okay.
And from a clinical perspective, I think individuals are sensitive to different changes in different medications, but also brand to generic and then different manufacturers of generic. Clinically, I want to make sure that it's not that, oh, only brand of everything is good and generic is bad. There are wonderful options for many, many medications that are generic, and it does make it cost effective. Some people are sensitive to those changes. Sometimes there's a filler in one that's not in another, and sometimes we have to just be paying very close attention to it. And again, that just kind of brings up that idea of discussing risks, discussing possible adverse effects. It doesn't mean that we're against someone taking a medicine or taking a generic even. It's just, hey, if you notice a change, let me know. Maybe it has nothing to do with it, but at least we're discussing it and open about it. So does quality change? Sometimes there's a very big discrepancy between, okay, a brand comes out in generic, I have lots of patients complaining about, I don't even feel like I'm taking anything, or all of a sudden it seems like it's hitting my system too fast. This should be long acting and brand did great, but this doesn't. And so then I can get prior authorization for someone to get cost down on brand if they need that. So there is a balance of, I don't want to demonize necessarily all generics, but definitely you think about, well, generics, and then when the people are getting it from online companies that don't even have regulation, or, there's just this continuum of safety, efficacy, and then what ingredients are in there, and then what do we know about it? But as a physician, I lean on what the FDA does day in and day out. It's extremely helpful, important, and critical for patient safety and for monitoring as well.
Yeah, I mean, for example, the color dye used in pills can be very significant as to whether a patient can tolerate. Whether or not, if you're halal, a lot of times pork products are used in excipients, so you'll need to be aware of things like that. But that's why it's really important for the patient to tell the doctor, don't just tell me the drug that you're taking, tell me the manufacturer, so we can really be sure that you're using a product that is right for you. And oftentimes that information is overlooked when physicians kind of run helter-skelter to treat a patient without really understanding what they're doing.
So bringing us back to trans-related interventions. So we know that everything's off-label. It's generic. These are old drugs for the most part. So that means that there's not a lot of financial incentive for the manufacturers to run a clinical trial for this use. Is that correct?
Yes. So you ask yourself, well, if you're going to have a whole industry who are selling generic drugs for off-label use, and it's very political and it's very public and there's a big debate about it, and one of those debates is patient safety, probably, at least to my mind, the most important debate is patient safety. Why don't the companies run clinical trials to say, we've done clinical trials, we have really solid, well-designed trials to show that it is safe and it is effective. And the reason, Jamie, to your question as to why they don't do it is because it's incredibly expensive to do it.
And the other thing I think to add to that, there are, again, off-label use, and what we're taught in med school and residency, and this is all constantly a part of your training, that yes, off-label use is okay, but you've got to make sure that it's justifiable, that the risk, the lower the risk and the level of benefit, if very, very low risk, but high benefit, and we know that, in other populations, patients respond well with not a lot of side effects. Okay, then maybe that is justifiable. A good example, as we were talking about generics, propranolol is a blood pressure medication. It's approved for blood pressure at very, very low doses. It's very effective for anxiety, especially performance-related anxiety, or someone's giving speeches and they get nervous and their voice gets shaky. At very low doses, you can take propranolol. There's not really financial incentive, I guess, to go do research, but we also know that it's been around for a very long time. At 10 times the doses for blood pressure, there's safety and efficacy. We still look at heart and cardiac issues. I ask any patient that I might consider starting on a low dose propranolol, I ask them about it. I ask them about, do you have any cardiac issues? Do we want to go ahead and get a cardiac workup if needed? Do you have asthma? Because it actually can affect asthma. We won't get into receptor details, but overall, it's a very well known, very commonly prescribed medication for other things. There wouldn't be an argument to go get it FDA approved for panic disorder or for performance anxiety, because there wouldn't be additional information that would guide clinical practice.
Okay.
So there are times where it makes sense, I think, even from a medical perspective and safety perspective, that, okay, we have so much information, but what I'm not doing is I'm not prescribing, 2,000 times the amount of propranolol for performance anxiety. I'm not going way outside of regular prescription parameters.
Okay, I think we need to go into a word here that I have used and both of you have used since we hit record. And that word is efficacious or effective.
Okay, so efficacious is in the lab, effective is in the real world.
Okay. But what does it mean that a drug is effective or efficacious? What does that mean based on the what is it? Is that talking about what it's treating?
Okay, so take a step back. So, a drug is not approved by the FDA because it is effective. Okay, it is approved because the balance between risk and benefit is positive. So, if you say, well, if I have a really bad headache, rather than taking 2 aspirin, I'm going to take 30 aspirin. Okay, everybody would say, well, don't do that. That's stupid. But that's the whole concept, that a drug is approved because it has a positive risk benefit ratio based on a dose, which is a proper dose, which is based on scientific data, right? So when you say the drug works, it then begs the question for, well, who is it working for? How did it work? What did you want it to do? And what were the side effects? It's like, wow, this drug really worked for me, but now I can't. Now I'm paralyzed. It worked is very, it's a very one-dimensional answer. If you're looking at it, if you're looking at a certain category of drugs, for example, in transitioning, and you can say, well, it worked. Well, what did it work for? What did you want it to work for? And then what were the unintended negative consequences that also happened? Because both of those need to be looked at simultaneously to understand whether it was kind of a good, solid medical decision.
Okay. So if I have a male that I'm going to give estrogen to, my first question, I guess, that would have to be answered is, what am I taking it for?
Well, the first question is, why am I giving the patient this drug? Okay.
Okay.
I'm giving the patient this drug because the patient wants to transition. Okay. So will it accomplish that? That's the first question a practitioner is going to ask. The next question is, it may do this, but what else will it do? And so,
so when we first started giving estrogen to men, was the question, we're treating that it'll turn you into a female?
Well, yeah, I'll punt that one to Lauren, but I guess the question that I think has not been asked is, okay, I'm giving a man estrogens. I want to accomplish this. I want the man to grow breasts, for example. What else is going to happen in this person's biochemistry that we need to take into consideration?
Well, and also, but looking at backing up even further. So when someone comes into my office for the first time, right, we start out with a full diagnostic workup. It's a full intake. You know, we go through medical history, developmental history. We go through what medications they're taking now. We go through things that they're struggling with currently, things that they feel are causing distress. A lot of times, there can be 10 things that come up the very first time I meet someone. There might be 10,000 other things that are contributing to what's going on. And that's part of, I think, what complicates being human, is that there's so much in our conscious as well as our subconscious and unconscious that contribute to our mental state as we are right now. So when I first talk with someone, maybe they saw on TikTok that they met criteria for ADHD. And if they come in and say, I saw online that I'm pretty sure this is my diagnosis, I need you to prescribe a stimulant. The one thing I don't do is say, you're right, here's your prescription. And this is where this area is so completely different. So if someone comes in, I still do a full workup. We still talk about all of the different contributing factors. We talk about trauma history. We talk about suicidality, and has that ever been present? Is it present now? We talk through all of those things. Then we talk together about possible interventions. Psychotherapy is an intervention, and it's a very effective one. And we talk about, can we minimize medications and hopefully try and work through things. And this is my approach as a physician: the least number of medications and lowest possible dose if medications are necessary is the safest route I can take. What I don't do is jump to, okay, if you say this is what it is and you want this medication, let's not worry about whether or not a stimulant might worsen panic disorder. Let's just go ahead and write the prescription. And by the way, what would you like your dose to be? So I think that's where, to me, that's a vending machine, not a doctor. And so when we look at what's going on now, that comes all the way back around to, what are we treating? And so it's not about, let's have a patient come in with the answer first and say, here's what I have, I need you to prescribe this. We're looking at what is feeding into it, what is going on, especially with mental health. And then once we've done that, let's talk about possible treatment options. And then we might talk about a stimulant. We might talk about if someone's struggling with depression or anxiety. We might talk about psychotherapy, but then also consider, an SSRI or a different antidepressant. To me, in this gender affirming world, it's become a backwards process.
Okay, Jamie, another really a relatively new phenomenon, but an incredibly dangerous one, is go to the doctor for a prescription. I don't need to go to the doctor for a prescription. I'll just go online and get the drug, quasi-legally or illegally or from a suspect website. So as we empower patients to own their own health, as we should, you have the unintended consequence of people saying, I'm not getting what I want, so therefore I'm going to simply not talk to a doctor at all and just get it through other means.
Okay, let's go into the petition to the FDA. So there is currently a petition that was a citizens initiated petition to ask the FDA to do what?
So what is a citizens petition? So there are, if you think the FDA should stop something or start something or do something different, and you're just an average citizen, you can petition the FDA to do something, and that's what we're talking about here. Is a petition to address the off-label use in some circumstances of estrogen.
Okay.
In males particularly, correct?
Yes, correct.
So can I ask, what is the current approved, what is estrogen currently approved for through the FDA? Is it, because it must have some kind of approval if people can prescribe it at all, right? So what is it actually approved for? And in any of those circumstances, is it approved for males?
Well, the one indication I know that was a kind of a secondary indication. It was for night sweats. I think that might have been one of the first, secondary indications. I don't know Laura, what the initial approval of estrogen was. It's ancient.
Mm-hmm.
Yeah.
But I guess the point is,
But night sweats in females.
yes, but I'm
Oh,
saying,
menopause.
Yes,
Yeah.
yes.
even
Yeah.
though estrogen is old, and I have to admit I haven't really looked at the label, it doesn't mean that it can't evolve. The problem with a old drug being used in very dramatically new and different ways is that no one's going to do large scale clinical studies because the money isn't in it to do it that way. So it's all based on very anecdotal evidence by certain types of physicians. The data collected is very questionable. Any clinical trials that were run are small and not controlled. So the problem with a product that's been around forever is that no one's going to really invest in hardcore, large scale, expensive clinical trials.
And
Okay. So
Lauren-
can I ask one more question? Are there circumstances in which drugs are only tested on one sex or the other? Like, if hypothetically, if estrogen was approved for night sweats in menopausal women, I'm assuming when you do clinical trials, there are no men in those trials.
That's correct.
So does
the clinical trial? I'm
okay,
sorry.
but if it's only tested on one sex and it gets approval, it is still allowed to be prescribed off-label to. It would still be allowed to be prescribed off-label to the other sex, even though there had been no clinical.
And I just remember clinically, there's a huge difference between allowed or legal and medically ethical,
Yes.
responsible,
Thank
safe.
you.
Certainly, we could get into effective, life-saving, all of the medically necessary, all of that stuff. So that is absolutely that in just the practice of medicine. You don't hurdle all of those things and just throw ethics and safety to the wind. But technically, could you off-label use something like, sure, that you can.
The part of the problem is it becomes a legal problem too, because if a physician prescribes a drug off label and something goes terribly wrong and the patient has a horrible health event or dies, the doctor can say, I prescribed the drug on label. I did exactly what the FDA said was appropriate. And sometimes life doesn't work out. You get poor therapeutic consequences. Some of them are terrible. When you prescribe a drug off label, and oftentimes way off label, and something horrible happens to the patient, then the doctor opens themselves up to serious malpractice situations.
Absolutely.
And I want to jump in to Lauren Legere to answer one part here. We should not forget that for decades and decades and decades, estrogen, progesterone, combinations of both, all of these are what are in almost all of the birth control, the hormonal birth control that is used, again, for women and girls. And that some of the very early trans-identified men who were taking who were seeking to take hormones. I remember one case, it was people that were taking birth control pills. So they were there's a huge market for birth control pills that have estrogen or estrogen based or those hormones are in those. Just to throw that out there. That it's not just menopausal women or the use of this hormone for those.
Right. And there are warning labels and there are risks listed in every package insert, which is a huge help from the FDA to all prescribing physicians so that we know what to look for. So if someone has pain in their leg because they're on birth control, and this is an approved prescription, I still have to be able to talk with my patient about, okay, there is an increased risk of blood clots. And so especially if you're smoking, now it's exponentially larger. So please be aware and let us know immediately if you experience X, Y, or Z. So I think that's where, one of the things that has come up or pushed back to our petition is that somehow that we're for banning anything. Regardless of my opinion of whether or not this is an appropriate use, no one's advocating for banning anything. This is truly looking at, can we please talk about why anyone would be against warnings?
Okay. So,
Yeah,
so there's a citizen petition, though, to the FDA to do what you're talking about, Dr. Lauren, which is to look at the use of, can you explain what the petition is asking the FDA to do?
sure. So part of, and I think kind of going back to the reason why we petitioned in the first place is that this use off-label of estrogen in natal males to experience or go through secondary sex trait changes in transition, and it's not approved for it, but all of a sudden it became rampant. It's commonplace. It's considered and told to patients this is first line, and to a lot of patients we know it's medically necessary. It's life saving. You've got to be on this.
That's what they're being told.
Correct. And so also, and that's kind of side note there. Remember, if a patient's going to talk to me about side effects, they have to not fear that I'm going to immediately pull them off of something. And if they have already been told this is the only treatment, the only thing that will help save your life, you better not complain about side effects. Well, how often are we going to get to have honest conversations with patients? Because I think their fear is, I've been told I'm going to commit suicide without this. I'm going to die without this. This is medically necessary. I have to be on it. But if I tell you my leg hurts, what's going to happen? So that's kind of a side note, but something that had not been researched, there had not been widespread data on this particular practice and prescription off-label. All of a sudden it is everywhere. We're seeing large numbers of folks on these medications or hormones. We petitioned the FDA because all of a sudden this was mainstream. And that's
and there's a lot of very high quality evidence to prove it.
Yeah.
So when someone says, well, estrogen, is that really meant for me? Wasn't that meant for, post-menopausal women? And the response you get is, it's been around forever. It's very safe. Now that's a true statement taken out of context. And what the citizens petition tries to do is to say, okay, let the answer to your question is a clinical question. Here's the data to answer that question, and you may not like the answer.
Okay. So the petition was submitted to the FDA and it was accepted. Do they get to say, no, we don't want to take a citizen's petition, or did they accepted it and then what did they do?
So all citizens petitions are accepted, even the silly ones.
Okay.
Unfortunately, but the people at the FDA are very sophisticated. Don't kid yourself. They know a dog when they see it, and they also know spam comments when they see it as well. The FDA is going to review the citizens petition. They are going to discuss it in great depth, and they will make a decision based on the clinical value of the argument. What is not going to drive their decision, are volumes of comments one way or the other.
Okay, well, we need to frame that up. So the petition was accepted, it went live on their website, and it's in this moment in time now where anybody listening, anybody can go find it online and they can submit a comment. Okay, so there was a wide group of organizations and MDs and individuals who worked together on the language, submitted the petition. In transparency, LGBTC was one of those organizations. We agreed and we worked to get this moved forward. And so it went live, and then all of a sudden, maybe 2, 3 weeks ago, the organizations that worked together to submit this petition got a request for comment from a very small, obscurish trans journalist website. Sorry, called, what was it called?
Needle News, which kind of is not as funny as I think they meant it to be. But yeah, Needle News sent out a huge
They wanted
blast.
to ask everybody for a comment who was part of this petition, and they wrote a story about this petition. And all of the sudden, the comments on the FDA petition went kind of, Peter, you know about I mean, the number of comments, is that like really insane, the number that it jumped to?
Because it went from under 100, maybe, was it? Like, I know there were 61 posted of maybe 100 and something to now I think we're at 79,500.
Thing is, don't let the numbers fool you. They are all equally useless. It makes people feel good to do it. It's action that doesn't have impact. And Lauren and I have talked about this. Is you can't give voice or credence or weight to people that are self-destructing. If it's 7,000 or 79,000, every additional spam comment just decreases the reliability and the consequence of the people who take those positions.
I don't think, to be fair, even when we were submitting it and then people were commenting on it, it works both ways. It certainly wouldn't have been beneficial to have 10,000 or 79,000 people saying we just don't like estrogen. Yeah, I mean, you wouldn't. So I
It's
think
not a vote. It's
right.
it's not a vote where the side with the most comments wins.
Mhm.
It's all about what do the comments have to say of consequence.
Okay. So all of a sudden, there's this huge spike in the number of comments, but then something else started happening on a more personal level. So,
Well, first of all, let me say that the fact that there are all these specious comments being sent into the FDA, I think is fabulous. I think it really shows that the citizens petition was precise, it was scientific, it was targeted, it makes a very strong point, and the people on the other side are basically having an enormous temper tantrum.
because so if the FDA accepts this petition, what is the outcome? What could occur? What could the FDA do to the use of estrogen if the petition is accepted and moves forward? What could happen?
You raise an important question, but it's not a question of whether the petition is accepted, because the FDA can make the changes suggested in the petition, and then that's all. They can do that and other stuff, or they can do other stuff and not what the petition wants. It basically calls the FDA's attention to the issue and suggests a path, the best path to advance the public health.
Okay,
but this petition
asking?
is asking, thank you. What is this petition asking?
Yeah.
So first, it's looking for the FDA to put together a research program. So not conduct research, but dig into all the research out there that we currently have, look at not just safety and whether or not it's effective, but also look at, are there harm signals? What do we not know about this use right now? So raising awareness of what we do know and what we don't. And both are important. And I think we also ask for a public hearing to discuss those risks and benefits and what is known and not known. We also ask for a boxed warning because at the end of the day, we know it's being prescribed.
So wait, do you know what a box warning is? So a boxed warning, otherwise known as a black box, because the box is black, has black lines around it, is a call out to physicians that speaks to specific high risks.
And there's plenty of medications out there with boxed warnings that are prescribed day in and day out. It's a great kind of red flag to physicians to not to say, hey, don't prescribe this. It's to say, hey, if this is something that you believe is going to be beneficial and that benefit outweighs the risks, one, you need your patient to understand that. And especially the high risk that we're talking about, they are aware of it. But you also need to make sure that in kind of outcome and watching for these things that you can also explore other things. You can, but it's not just say, hey, don't prescribe this, don't touch this. This is a terrible medicine. But it is something very, very useful, and it's to protect patients. And I think that's, when we talk about people that are opposed to this position, I think that's what's heartbreaking is all I think the petition is asking is to protect patients and protect individuals from harm, to let doctors know, prescribers know, and those that are taking these, that there are things to be concerned about. I don't know how that's become this terrible thing to say. Medications have risks. And if you're in medicine and you're prescribing things and telling people that there's no risk when you put something into your body and alter anything, I don't care what system you're talking about, and this happens to be one that alters plenty of systems, that's not medicine. That's dangerous. And so it's again kind of demonizing the risk profile. We have to know about it as physicians. Patients deserve to know about it. That's part of good care.
Yeah, I think what Lauren L was getting to was this petition. Now, if you read the very inflammatory, nasty comments for those who don't like this petition, what they're saying is that this is going to prohibit the use of estrogen in a variety of circumstances. Nothing could be further from the truth. All this is saying is it's important that doctors understand that there are some serious issues that they need to really think hard about. Not even that they've got to tell their patients, that the doctors themselves have to think about it. And that's being improperly translated into these people want to prohibit the use of these products. Absolutely not true.
Is the black box warning kind of the limit to, I guess I want to say, the FDA's teeth? Like, so they could put this black box warning, that's pretty much all they could do. They could not say you can't use this medication.
So I'll give you an example. So there are a lot of drugs out there that you should not give to people with liver disease, for example, right? Highly toxic. Patients die because they have liver disease and they've taken a medicine that will make their liver disease advance to the point of no return. Okay. That doesn't mean that a doctor can't prescribe it. It means that it's incredibly bad medical practice. And the doctor will then also think, oh, and by the way, I'm opening myself up to a career-ending malpractice suit. Okay. So even if a doctor chooses to go forward with an absolutely outrageous use of a FDA-regulated medicine, they still can do that.
What are the known risks right now for giving men and boys estrogen? Because part of this is we don't know, but part of this is we do know some things. Can you give us like an overview of like what do we know so far?
I'll let Lauren answer the bulk of your question, but one thing that's really important is that for a lot of products, just writ large, there are very few of them that actually have clinical trials for children.
Correct.
And as a result, when you label a drug for children, it's absent. And when you prescribe a drug off-label for children, you're guessing. And a lot of those guesses are smart, and a lot of them are intuitive, but they're guesses. There's very little clinical evidence when it comes to almost every drug that is not indicated specifically for children about the use of those products for children.
Yeah, and so to just kind of jump in, and that's where the risks, if anyone wants to see a full list of them, we've got them listed. We also, the review that we did on estrogen, published it last year. We looked at really anything that we could look at in terms of harm signals. But remember that the research in this particular population is difficult to get to. That was one of the reasons I wrote the review that I did with several wonderful co-authors, and we looked at just anything and everything harm signals, whether it was known, especially in the populations that it's approved for treatment in. And we also looked at, okay, as people were reporting side effects and harms, we were trying to find even if it was a case study, because I think that kind of goes back to when we look at, you hear systematic review used all the time. That's the gold standard, and we want to systematically review how a medicine is effective in treatment. And as a prescriber, if I prescribe it, how effective is that medicine going to be, and how much can I rely on that outcome? But that's very different from harms. In terms of harm signals, waiting for all studies to meet that threshold of being even able to make it into a systematic review, you have to be at a certain quality level, and that kind of gets in, we can get into the weeds into that if we want to, but any harm signals, especially if they're severe. So we're talking about, blood clots, stroke, blindness from a retinal vein occlusion, different risks of cancers that we know either we see in different populations that are prescribed this, we see occur in medical conditions that maybe, let's say a male is, their body is producing too much estrogen, or we see tumors that produce, different hormone signals. And then mortality risk. We look at all of these different risks because this isn't a prescribed, FDA approved, and very in-depth researched practice. We don't have access to studies like that. So right now we're relying on these harm signals, but because they are there, you don't ignore them because, well, the research hasn't been done in this particular patient population. We know harm is occurring. And so I think that was one of the reasons I wanted to be involved in a lot of this to begin with, that whether it was a patient coming into me experiencing harm, or I was hearing families talk about it and their experiences, that everyone, including doctors, are being told, no, this isn't harmful, this is life-saving, this is a medical necessity, and these have to be prescribed, get out of our way.
Also, doctors, and I don't want to speak for you, Lauren, but I know you're on the right side of this issue. Doctors are ethically obligated to report adverse events. They are not legally required to report adverse events. And there are a lot of physicians in this space who are prescribing estrogen therapy aggressively, which then generate negative consequences that they are not reporting to the FDA. So the fact that there are as many examples of adverse events out there right now, you have to figure there are, 10x times as many out there being suppressed.
I just need to ask this really pointedly, quickly, though. Lauren, a number of the conditions that you listed, the worst point outcome to a stroke is that someone will die. Is that not correct? I mean, we are talking about
Risk of death.
that the outcome could be that this person could die from the use of this.
Absolutely. Yeah. And that, I think that's something that, to say that just either that, oh, well, we don't know enough about it, so keep prescribing until we do, doesn't make any sense, which is arguments you hear for the continued use in this patient population. And yes, I mean, death, you also, I didn't even mention fertility. When you intervene and you create a situation that takes the ability away from someone to have their own children, whether in the moment they are saying they want to or not, you're taking that choice away. And there's risk to fertility. There's risk, and we didn't even get into pain and suffering. And I mean, the list goes on, and these patients are being ignored. They're being told, if you stop this, you're going to commit suicide. It's just devastating. And then you have to also look at, I talked about before, if a medicine impacts one system, so in one organ system, whether it's cardiovascular or, your neurologic system, or those side effects can be severe. Now we're talking about a hormone that impacts multiple systems, and it's over time exponentially gets worse and worse. So as these patients, which if you think about goal of transition, if you're transitioning and staying on estrogen your whole entire life, as these patients age, the risk becomes greater and greater, and that mortality risk becomes greater and greater.
And also, we're talking about a population in the citizens petition. We're largely talking about a population of non-adults, of adolescents. And the question becomes, what is the ability for a person in that age zone to make a practical, thoughtful, fact-based decision minus the intercession of a responsible adult.
And
So
additionally,
it's,
yeah,
yeah,
oh, go
I'm
ahead.
sorry.
Oh, I was just saying, I would add to that informed consent, which is required in that, conversation you're having with a patient about any intervention, whether you're a minor or you're an adult. If you're not having conversations about risks, you're not informing them. If you're not giving them a justified reason to utilize such a risky intervention with known and unknown. We've got known consequences and known outcomes that are devastating and can be permanent. And then we have so much that's unknown, even to an adult, having the conversation about we don't know long-term side effects cognitively, what this is going to look like in 10 years, in 20 years, in 30 years. You have to be able to say that to that patient. That's not what they're being told, or it's the opposite. They're saying, well, because we don't have data on this particular patient population, we're just going to default to it's safe and
Or,
effective.
or what really upsets me the most when the doctor says, well, in my experience,
Mhm.
this is what I found. Um, that's a fancy way of saying in the 10 patients I've seen.
Right. And saying long term, 12 weeks isn't long term. When you're talking about a patient that will be on this for years and years, or that's the plan by the prescribing physician that they're going to be on it indefinitely.
Yeah.
That's
And
an
then
issue.
also explain to a patient, I mean, it's easy to say, well, if it doesn't work, you can always stop taking the drug, which I guess is true, but it's a lot harder than it sounds.
So let's go into the short time we have to wrap up. The both of you put your name out there and help to work on this petition. And now, has there been fallout in your own lives over doing that? Can you
I
tell
mean,
us a little bit about what's been happening for you since?
Well, it's been,
well,
I mean, go
go
ahead,
ahead.
Laura.
Oh, no, no, go ahead. You go first.
On my end, there's been a lot of hate mail. Um, there have been a lot of comments from my friends, my social friends, as to how could I say these things? What are you, some crazy Trumpy? It's interesting that when somebody doesn't agree with your, kind of considered data-driven decision, that it can't just be a discussion on science issues that you don't agree on. You have to be 100% wrong and evil in every way. So there's been a lot of demonization that's very, very uncomfortable.
And absolutely. I mean, there has been, less so until this petition, and much more so since. But certainly just that, you know, what I said early on, that idea of it being somehow, you know, lacking compassion or controversial to say that, okay, can we consider maybe providing every patient the best possible medical and mental health care and know that talking about risk versus benefits is responsible medicine? It's just been remarkable, the pushback. Certainly, I think again, it's just the idea of politics not belonging in medicine. Medicine isn't political. I don't. It's my job to leave my beliefs at the door and treat every single patient, whether they believe same or differently on religious issues or political issues or cosmic issues. I'm treating every single patient to the best possible level, to my best ability in every situation. With this petition, truly, we're petitioning to help patients and providers be more aware of the harms that we are seeing, the lack of evidence in areas that we've got to know what's going on. And I think that's where it's become, what I've seen recently, especially with the FDA petition once it was posted. Truly, there's been other things that I've spoken out about that I thought this isn't going to be controversial. I mean, this is just
But
it's very clear in medical, and then all of a sudden it's I'm transphobic or I'm out to make a list of all people trans so that we can get rid of trans people, which is heartbreaking because every single one of my patients, I don't care how you identify, you do deserve the best possible medical care, and that's not what this is.
I think the value in understanding what's happening relative to kind of the personal attacks is that I love it, because what it shows is that we're winning. That the other side has no more scientific, they can't argue the science because there is no science to support their proposition. So they have to turn to other types of personal, nasty cyber attacks and so forth. But at the bottom line, it shows the FDA is going to be judging a petition based on the science, which has really gone unrefuted in all of the anti-comments on the website.
Yeah. And that's what's hard is even my, my own private practice has been called dangerous to anyone in the, you know, that
You can say the LGBTQ.
No, well, I was trying to come up with I was trying to use not the language that was in some of the comments. I was like, that's not appropriate. But just LGBT community. I mean, all of that is that somehow I'm dangerous, and please warn anyone that you know about not to come see this person. And I'm working on, I think, that forward facing, maybe less impacted, thicker skin, on an advocacy perspective. This has just been different, and I don't know what has made it different. Because again, when you read the petition, it's pretty straightforward, and it's just looking at what we do and don't know and asking for more clarity, and more support for physicians and for their patients. And to me, that is absolutely pro LGBTQ. Like, I don't think that it's okay to provide a certain subset of the population with substandard care and not warning them and creating a situation where they may not be able to have their own children, or have, now not even elective, but now required surgeries because of challenges that a blood clot has caused or a stroke has caused, or, there's so many different aspects of this that are, I mean, to me, this is it's pro medicine. It's pro better treatment of all patients.
Lauren, though, I do want to, you're being very diplomatic right now, but you have had to consult legal counsel. I mean, this has been almost on some level an egregious and sometimes personal dangerous attacks.
Mm-hmm. Yeah, and that's been different. That's been that was I think maybe I was naive to what would start to appear, and whether it's, in my inbox or on a phone call, or, so that's been more disconcerting. And I think what's been wonderful is just how much I think everyone who has worked on the position, everyone who's supportive of the petition, everyone who's supportive of better patient care and raising public awareness of what this is and what this isn't, that's where I've really, I think, leaned in, and that's been really helpful. But it's been scary. It's been and sad knowing that I've dedicated my whole life to providing the best possible care for patients. And sometimes that I have to have the hard conversations about, this medicine may not be best for you, or this medicine may not, or this may be causing side effects that are actually really detrimental. And that has never been an issue in the past. So it's just, I guess I have kind of hit that threshold. And my hope is that I'm at the peak and it settles. But we'll see.
Well,
said.
Yeah. You're getting the help that you need right now. You're getting the legal assistance. And you're still wanting to move forward. You want to see this petition succeed.
Oh, absolutely. No question. I think to me, whether I move forward with it or not, I think what I've learned, at least in the last couple of weeks, is that it really doesn't matter. The words are going to be twisted and presented incorrectly no matter what. And all I can do, I think, right now is just I can continue to tell the truth. I can continue to, anytime there's something that I'm not fully informed on, I want to learn more. If there's something I'm wrong on, I would love to have those conversations. And that's where I want to be. I don't want to ever close that off. Um, and so hopefully, I think as we move forward, the more clear this can become, and I think the more people can see, we're fighting for patients and we're fighting for not just their treatment right here and now, but their entire lifelong well-being. And that's always been the case. So
Yeah.
this isn't new.
And what's nice is to have the petition out there. So when people say to me, you're a transphobe, look at the data. You're a Trumpy, look at the data. You hate gay people, look at the data. There's no value being sucked into arguments that are not part of our discussion.
Peter,
Look at,
you might not know it, but you're really good you should be on like an Instagram reel. Like, I'm this, look at the data. Look at the data. You got a great
I mean,
little clip right
I mean,
there.
the problem, I think, Lauren's point is key, which is when you're a professional and you're making judgments based on your professional experience, based on the best science, based on the data, based on based on the intake you've done with a patient. A patient can follow your advice or not, but every patient comes in with a predisposition of what they think their care should be. And some patients want to be collaborative and some patients don't. And if patients get belligerent, they should go someplace else. But when groups try to shut down medical professionals who simply don't do what they want them to do, that's just criminal.
And it leads to poor outcomes for everybody. When we talk about, yeah, that leads to a system that doesn't protect evidence-based care for everyone. So we need the robust oversight and systems to remain in place so that we can all trust what happens when we go to the doctor. Well, thank you so much for joining us today. I feel like we could pick both your brains more in depth on psychiatry, on FDA practices. When does the public comment period end? And then we probably should make sure we have you back when we see what the FDA is going to do with this.
I think we're coming around to the end of the comment period, actually. Why you had this flurry of garbage coming into the agency, in one fell swoop.
Okay. So we will put in our show notes links to the petition. We'll try to find that Needle article if we can. It was interesting.
No, don't give them any more oxygen, believe me.
Okay. Okay. And then hopefully we can talk again soon when we see what the FDA does with this.
That would be fantastic. I would love to.
Thank
Thanks
you so much for joining us today.
Yeah, absolutely. Yeah. Thank you guys for having us. I think hopefully this will help a lot more people understand kind of what we're fighting for. So,
Yeah, thank you so much.
yeah, absolutely.
Thank you for joining us today on Informed Dissent. Before we close, we have to note that this is going to be the first time in the history of our show that we have dedicated an episode to someone we have lost in our movement. This episode this week is dedicated to Ron Miller. Thank you for being here. If this show matters to you, please share it with a friend, a colleague, a family member who's been asking questions and not getting straight answers. Leave us a review, subscribe wherever you listen, and find us on Substack for the full newsletter with sources and links. I want to thank our guests this week, Dr. Lauren Schwartz and Peter Pitts, for bringing clarity and courage to a conversation that needs both. And thank you to Lauren and Corey, my weekly co-hosts, and to the whole LGBCC team for the work that makes this show possible every week. Before we go, we want to sit for a moment with the loss of Ron Miller. I knew Ron, just like I know all of the people who started Campbell Miller Payne. And what they built, if you're not aware, is not a small thing. They created the first law firm in this country dedicated solely to representing detransitioners. And when they did so, there was no roadmap, there was almost no case law. This was an open legal question, and this was a real fiscal risk. Other attorneys saw the same landscape and they walked away, and Ron didn't. But what I want to tell you is something else about Ron and the men at that firm. I'm a mom, a liberal on good days, a lesbian, and they never made me feel anything but welcome. And they were the dads. And that's the only way I really know how to say it. in their day-to-day work when we had meetings and they joined me on Zoom from their office. In every single conversation, they were driven by exactly what drives me, which is the care for kids, for all of our kids, for their own kids. And they were always just the dads, and they never judged me. They pulled me directly into parenting conversations, and we would talk about all of our children. And believe me, we have a lot of children combined. But the way that parents just do, and that's who they are, and that's who Ron always was. He was 38 years old when we lost him this week, and he leaves behind his wife and his 4 children. Ron, you will be greatly missed in this movement, but we will carry it forward. So to all of our listeners, in memory of Ron this week, please stay informed and ready to dissent.